The first thing I want to talk about is the importance of having some sense of legality and tracking around the dissemination of your data. And this has been a big driver for us because a couple of years ago when I got into this position, one of my first questions was, okay, who do we give data to, where is it, and what do they do with it? And we couldn't really answer that question. And so in addition to cataloging our data sets, we're now centralizing the process of putting out data sharing agreements. And these agreements are pretty straightforward, but they are legal binding documents that help us to know exactly who's receiving what data and for what years, what variables, and how they're allowed to share it and how we're allowed to share with them. So we've done data use agreements lately for Lynn County and Blackhawk County because we're giving them a lot of data in an individual identifiable form, and we want to make sure that we just have a common understanding of how those data are used. We also have relationships, even though the Center for Congenital and Inherited Disorders legally manages that registry on our behalf, we still want to allow the researchers the ability to do surveillance, to do some descriptive epidemiology and look at those registries. But we also want them to share that information with us. And so data sharing agreements help facilitate that use. So another agreement type we have are research agreements. Research agreements are just strictly for requests that are for the research use of data. And we even have the word research defined in our policy. So we have some core criterion that we use to evaluate this. So we all know what IRBs are. Well, we have a Research and Ethics Review Committee. We are not an IRB, but what we do look at are things like, is this study of intrinsic value to the people of Iowa or its findings? Are there aspects of the research proposal that might raise alarm for us? In other words, I can think of a great example. We recently had a request from a doctoral student who wanted to get all of the marriage license application data for any couples that identified as same-sex. Well, we thought, well, that's an interesting study. Nobody's ever asked us for that data before, but then again, we have it. But when we took a step back and we thought, you know, we can release those data for the purpose of research, but what really is the ethical way to approach that? And we haven't even made a decision on it, but we pushed back to the researcher and we said, you know, first of all, we feel like it might not be ethical to identify couples as same-sex, even though they've indicated as such on their marriage license, that's not really our role. It's not our role to provide that information. But what we can do is maybe give you a list of everyone who was married, leave out those variables, let you contact those individuals, but let them decide, first of all, do they want to participate in your study? And second of all, do they want to identify as same-sex or not? So that was sort of a counterproposal. Now, like I said, we haven't agreed to release those data, but at least we had the opportunity to evaluate that application. We can see some value in the research, but the proposal needs to come along a little bit further before we have any level of comfortability around releasing those data. So we get about one of these a week, and these applications take an immense amount of time for us to sift through. If I didn't have background in doing research and in statistics, then this would be a really hard task. But we have the Bureau Chief for Vital Statistics and our medical director also sitting on that committee along with myself, and we meet every other week and we comb through these proposals. And it's really been a great experience for us because we can see where our data is going and all of the ways that it's being used in these really interesting research projects. But it's also motivating us to make sure we get our ducks in a row and work on things like a genetics policy and a data release policy and all the things that we need to make sure there's continuity in how we release our data. So I mentioned in the previous talk that we had a list of 54 data sets and systems in the department. Here is that list. So I'm not going to say with 100% certainty that we found everything that there is in our agency. We have 480 people. There are lots of people, sometimes in the corners of the Lucas building, that might be harboring data set they don't want to let go of. We've tried to find them, and we've tried to pry data from them, just for the sake of let's be friendly and share our information with each other. So I think we've done an okay job with that. So we have a lot of different data, and I don't want to get into the aspects of data, but we all know survey data is very different from registry data. We have a lot of survey data. We have some new systems like PRAMS, the Pregnancy Risk Assessment Monitoring System, that's brand new. but that system can integrate with other systems within family health. So this great list of data sets, we have data dictionaries and variable lists to accompany those. So some other things that I want to mention are around our tracking portal, and I'm sure the guys did a wonderful job. I've seen their demos before, and they do a terrific job in demonstrating the uses, but there are a lot of ways that we really hope the portal is used, and we want to hear about those. We want to know how you're using the portal, because that helps us to know, one, did we get it right? Two, how can we make it better? And then three, what are you using it for, and how can we tell other people how you're using it, because they might want to use it the same way. So we expect that there will be a need for China hip analyses, and we know hospitals now have to do that. So we want to promote to hospitals. We're trying to get the word out to them. Local public health agencies, we're absolutely partnering in that area. Community health planning in general, environmental systems planning, general public education, partnering with academia. I've heard a couple of professors lately say, ooh, I'm going to use that in my classroom. I used it in my classroom last week. Legislators and healthcare. So there's a lot of potential use cases, and we would love to know more about what you're doing with our portal. Okay, 2 case studies I want to just pull out as an aside. And again, these are sort of aha moments that we're working through, and we're trying to figure out, do these ideas have potential? And these are sort of on the periphery to the portal, but one ties potentially to the portal and one doesn't. So the first one is a dental community health indicators assessment. So this idea came to me, I think it was our deputy director sent me some late night email with this great graph that said, oh, we need to start looking at dental indicators. This is an important health issue. I'm like, dental? How does that fit in the tracking portal? Well, it's the health indicator. We can look at dental, okay. So I started to look into this, started to talk to Bob Russell, our public health dentist, and found that there are definitely some things or some rationale that we need to consider when we're talking about dental issues. So availability of, or the ability of patients to tolerate care when they have underlying conditions. We know that diseases and disorders have effects on oral health, but that oral health also has an effect on chronic disease and our own health. We have an aging population. Medicare doesn't provide general dental benefits. Medicaid provides limited benefits. As our population ages, the demand for dental care will increase. So there's a reason to start monitoring these things. This is the graph that I received from our deputy director. And it is really interesting to look at the trends over time from 2000 to 2010 by age group, that we're definitely seeing an increase in emergency department visits where primary diagnoses were related to dental issues. So we have reason to explore this. Some other things that I've been seeing is we've seen the Department of Human Services start to look at expanding their dental plan as part of health and wellness initiatives with Medicaid clients. So I included a link here just in the slides that I won't pull up today, but it's one you can go back through and look at later if you'd like. So then we started to try to examine, and I'm not going to take credit for this, all I did was sort of broker in between, but Tim, who's sitting up there, he's been doing this phenomenal analysis of our outpatient data. So we have inpatient data and we have outpatient data, and they all come from hospital discharges. Outpatient is a bit misleading. This is mostly emergency department visits, but it's a data set that we haven't tapped into, and we've had it for a long time. Well, the reason we haven't tapped into it is there are about 5 million records every year. So it's arduous, and you have to be pretty savvy to look at these data, but there's a potential for them to be very wealthy. So I went to Bob and I said, all right, how in the world do I find the ICD codes that would represent a dental diagnosis or a dental discharge from the hospital? And even in the emergency department. He said, well, look at this. These are the studies that I have. So we looked at those, we narrowed it down, and I brought them to Tim, and I'm like, can you do an analysis for me, and then throw in these variables, and let's see how many of these visits we can come up with. And so Tim did it in like a week and came back with this range. We had a 6-year period. He found 120,000 visits attributed to dental issues. That's a huge data set. That's a huge data potential there. And so I was so excited to shoot the email off to Bob saying, all right, it's time to talk. Let's figure out how to get this information out now. So some other things Tim did that were just wonderful standard practice that we'll be able to use in meeting with Bob and starting to grow and nurture this aspect of what will probably be part of the portal is he created a data dictionary to show us what codes he was able to put together and put in an Excel pivot table and for us to play around with. And so we know the limitations of the variables and which ones he has access to. Okay, so the next one that I want to do, I have a huge passion for child mortality and infant mortality. Yeah, those are my kiddos, and I serve on Iowa's Child Death Review team, and we meet about 5 times a year. It's a really tough subject to tackle, but we review a proportion of all child deaths for all manners and causes. And the one that's near and dear to my heart is sleep-related deaths. And I haven't experienced that personally. I just think it's an area of infant mortality we can still affect. Deaths due to sleep-related deaths and congenital abnormalities are still the leading causes of infant mortality and have been pretty stagnant over the last 10 years. So one of the things I started to do in working with this team, and in part in some of my doctoral work, was to look at their data. And the Child Death Review team has a child death database that they report to the University of Michigan School of Public Health. And we enter in, and I'm not kidding here, 1,700 variables up to for every child death case. It's an incredibly valuable system, and nobody has looked at this data, at least for Iowa. So I started to dig into the data, and I started to look at sleep-related deaths and put together a profile with the team members that I had working with me. And when we put together this profile, we saw some really interesting trends. We saw that there was still a high rate of co-sleeping, 29%. So if we take all of the sleep-related deaths that have happened since 2004, and we look at some of the risk factors, we see co-sleeping still happens. It should be a lot lower than that. That's much higher risk than blanket, pillow, comforter, yes. Co-sleeping with siblings or other children is that 7%. So the other thing we started to do too was break it down by race and ethnicity. Now we don't have the most diverse state in the world, but we do have some diversity, and I was particularly looking at the divide between Caucasians and African Americans, and so we parsed that apart too. So then we wanted to look at sleep location. So we knew co-sleeping was happening, but we wanted to see where. Is it happening in an adult bed? Is it happening on an unsafe sleep surface? We see a lot of couch sleeping or floor co-sleeping. Where was it happening? Adult bed. We see there's that blip with African Americans, the red blip right there, adult bed. So I wanted to parse it apart even further. And so when we did that, we saw that almost 40% of African Americans who had experienced a sleep-related death did so in adult bed, and they were co-sleeping. So breaking this down even further, we had a target here. And this to me said, all right, we know that there's a rate of sleeping with other kids, a rate of sleeping with other adults. I wonder if these people have cribs. I wonder if they have access to cribs. Maybe that's our issue. So I took these data and thought, well, let me back up here. I took these data to the McVie people. So McVie stands for Maternal Infant Early Childhood Home Visitation Program. I'd taken it to the committee and they said, well, Meg, you work with these McVie people. Why don't you go talk to them? I'm like, I don't know them, but okay, I'll go talk to them. So we set up a meeting and I showed them the data, and they were very excited about it. They were very excited to see that they actually had information that could help characterize their population and that there was a potential intervention that we could identify. So the next step then was to say, okay, figure out what counties we should interact with. And we haven't taken the step of contacting counties. All we've done is calculate some mortality rates. So we started to look at incidence for all causes, and then sleep-related incidents. And then we broke that out by the top counties and calculated their mortality rates. Then we also looked at mortality rates by racial and ethnic groups. Now, the ethnic groups I don't have up here, but the race groups I do. And you can see, just looking at the state, among African Americans, there's a huge disparity in mortality rates. So we could be doing a lot better there. There's also disparity between the different counties. We have a mortality rate in Clinton County and Des Moines County and Scott and Black Hawk that are higher than that of the state. And those are some of our leading counties in terms of infant mortality. So we've started to look at that specific data and then overlay it with our McV counties to see, can we do something in these counties through McV that might affect infant mortality? And I'm sure there are local initiatives, but this could be one more potential. So what we've decided to do with McV is to try to develop a profile for targeting crib provision. And they have funds to tie to this. Again, we have to make the connection with our local partners, but at least we're able to go to the local partners and say, okay, this is the profile of the people we're talking about here. We're talking about young parents, parents who may be unemployed, who have a very low level of education and are likely to be on social services. These are the parents we want to target. They're probably the ones that are also enrolled in McV. So just an example of data use in action. So a couple of other things are future plans, drawing it back to the portal. So, and if I've missed something, Tim or Rob, please let me know at the end here. Heat-related illnesses. So we plan on starting to work, hopefully with a vendor, maybe sometime early next year, expanding the portal, talking about heat-related illnesses, looking at outpatient emergency department visits for asthma. We're going to make some enhancements on our existing dashboards to make them more user-friendly. We're going to make enhancements to the county health snapshots, so you can select multiple counties and multiple years and the indicators that you want to see in your report. We're going to try to complete our department blueprint for informatics or data management, and that's been a big initiative tying with our larger department's strategic planning. Cultivating relationships with researchers in healthcare. And I've mentioned before, I think this is an area where we have a lot of potential, and there's a lot of bright things going on, as you've seen today, and I really look forward to cultivating those relationships. So lastly, I have somewhat of a public health challenge. I know the last couple of years when you go to a conference, a lot of the challenges we get are that personal wellness challenge. What are you going to do? What's your wellness goal going to be for the next 3 months or 6 months? Whether it's run a 5K or do a couch to 5K or some type of challenge. Well, the challenge that I'd like to leave with you today is an informatics challenge and a data challenge. It's taking the ideas that you've seen today and what's one way that you can employ one of these ideas. What new alliance can we make? What new connections can we make? How can we better utilize informatics? How can we prove that we have the expertise? And lastly, make the transition from a consumer to a broker. And so that's the challenge I want to leave with you today, and one that I hope to carry on myself. So any questions? I think we have about 5 minutes. No? Okay.
Well, let's give Megan a hand. Thank you.